Okay, on page 176, here's what we covered near the end of class last time. We gave you the terms systole and diastole. Systole is the period when, as far as we're concerned, the ventricles contract. Technically, if you actually read the book, systole just means contraction, and it doesn't specifically refer to either atrial or ventricles. They actually talk about atrial systole and ventricular systole. It just means contraction. But for our purposes, systole refers to when the ventricles contract. Diastole refers to when the ventricles relax. Now, we can divide what the heart is doing actually into 4 phases. 3 of the 4 phases are identified and pictured on page 176. The phase that's missing here looks very much like this phase in the middle, and I'll get to that later. I don't know if it'll be today, but we'll get to the 4th of these 4 phases. So on the far left, it says filling phase of diastole. What does diastole mean? The ventricles are relaxed. Why do they relax? The ventricles of our heart relax so they can refill up with blood. So that's what they're doing, and this is called the filling phase of diastole. Let's take a look at it. So we see that here's the right atrium and left atrium, and the blood is shown with the arrows filling up the right ventricle and left ventricle respectively. Certainly makes sense to call that the filling phase because the ventricles are filling up. Now, there are 4 valves associated with the heart. This is where, if you've forgotten your anatomy, this is where you should go and either reread or watch a video so you're clear on those valves and the chambers of the heart. Again, if you're rusty and you've forgotten your anatomy, it is your responsibility to catch yourself up. Now, I can't reteach anatomy. I don't have time. There's only 4 weeks left in the semester. So 2 of these valves, 2 of the 4 valves are called AV valves, atrioventricular valves, or I call them inlet valves.
You'd say, when did you tell us that?
At the top of the page. The AV valves are the inlet valves. Why are they called inlet? Because they allow blood to go into the ventricles when they're open. They allow blood to go in. And that's exactly what this picture on the lower left is showing on 176. The AV valves are both open and blood is flowing into the ventricles. Now, the other 2 valves of the heart are the pulmonary valve and the aortic valve. The anatomists commonly refer to them collectively as semilunar shaped valves because they have a similar shape. But I said we could think of them as the outlet valves. You'd say, when did you tell us that? At the top of the page. The pulmonary and aortic valves are the outlet valves. They allow blood to go out of the ventricles. And you will notice that in this picture on the lower left, both the pulmonary and aortic valve, both outlet valves, are closed. So what that means is blood is going into the ventricles, but no blood is yet going out. All right, so this is called the filling phase of diastole. Is everybody okay on that phase? All right, now, in the next 2 pictures, the next 2 pictures are 2 phases, both related to systole, both related to when the ventricles contract. And we described last class meeting that the way muscles contract is they contract in 2 phases. First, they develop tension, force, pressure, and then they actually shorten in length. We demonstrated this by, for example, trying to lift an object, and we noticed that even before we've actually raised it up off the table or raised the object up off the floor, we feel there's an increased tension in our muscle even before we've actually raised it or moved it at all. That process of developing tension within the muscle is called an isometric contraction or isometric phase of a muscle contraction.
You might say, when did you tell us that?
On the bottom of 177. That's called the isometric phase, where there is an increase in tension or force or pressure. And then, once the muscle has developed sufficient force, sufficient tension, sufficient pressure, then it shortens in length and there is movement. And we call that the isotonic phase, where the tension remains the same, but there is a shortening in the length of the muscle. There is movement. So this same thing applies to both skeletal muscle and also as well heart or cardiac muscle. So that's why on the bottom of 176 there are two phases both related to systole or contraction of the ventricle. The first of these is where the wall of the ventricle develops pressure. And the second is where it actually ejects the blood. It actually does something. So we call this first phase, where it's developing pressure, isovolumetric contraction phase of systole. You'll notice that in this picture, all four valves are shut. That means the inlet valves, the AV or inlet valves are shut. No blood is entering the ventricle. Furthermore, the pulmonary and aortic valves, the so-called outlet valves, are shut. No blood is going out of the ventricles. So, if there's no blood going in and there's no blood going out, clearly the volume is staying constant. That's why it's called isovolumetric. Same volume. But the walls of the ventricles are contracting. And as they contract, there's an increasing pressure as the walls are compressing in on this volume of blood inside each ventricle. The pressure is rising. Now, when sufficient pressure has been developed, then the ventricles can start to eject the blood. This is called the ejection phase of systole. And you'll notice in the picture, the pulmonary valve is open, and the arrow shows the right ventricle ejecting blood up into the pulmonary artery. Similarly, the aortic valve is open, and the left ventricle is ejecting blood up into the aorta. Again, if you're thinking, say that slower, Professor Fink, I didn't catch what you said. I know what the problem is. I've been doing this 35 years. You can't remember the order in which blood flows through the heart. You have to remember that. You have to review it. You need to be able to, and we covered this last time, you need to be able to write on a blank sheet of paper, not because I'm going to ask you to do it, but you won't understand physiology until you can say the vena cava, the blood goes from the vena cava to the right atrium, past the right AV valve to the right ventricle, pulmonary valve, pulmonary artery, lungs, pulmonary veins, left atrium, left AV valve, left ventricle, aortic valve, aorta. You've got to know that. Otherwise, every time I say the word aorta or left ventricle or right atrium, you're going, I don't know. It's one of those things. I don't know what happens. That's basic anatomy. And if you had me for anatomy, I made you memorize it and write it on a blank sheet of paper, although you probably still forgot it. Okay? So be sure and review the anatomy. Not because I'm testing you on that, but I'm testing you on the physiology, but you're still stumbling over, let's see, the right ventricle ejects blood where? The right ventricle ejects blood where? That's my question to you. Where is it going? The right ventricle ejects blood into the pulmonary artery. Right? That's what I mean. You don't remember where it goes. That's anatomy. And so I'm not here to teach you anatomy. You need to know it already. All right? And then the blood goes from the left atrium where? It goes from the left atrium to the left ventricle. You have to know it like this. Remember, we're talking about the structure of arguably the second most important organ in the entire body. And certainly from a perspective of nursing, nurse practitioner, physician's assistant, the most important organ in the body. Because you're going to deal with the heart more than any other organ. All right, so that's basic anatomy. Make sure you review that. Okay, so I think that's the two phases. And then after the ventricle ejects the blood out into these arteries, pulmonary artery and aorta, it goes back into diastole, where it relaxes to refill up, where the two ventricles refill with blood. Again, you have great videos that I've linked showing this in animation, where it shows it over and over. Okay, on page 177, the valves are very important because if the valves ensure that the blood flows in the right order, the right sequence. And if the valves don't work right, if there is a problem with the valves, blood will regurgitate. It will flow backwards. Now, what is the etiology, the cause of valve problems? It can be congenital, where somebody was born with a defective valve, Or it can be the result of something called rheumatic heart disease. Rheumatic heart disease is an autoimmune disease. It's where the person's immune system attacks the endocardium and the valves of the heart. Now, we know that there are hundreds of autoimmune diseases that attack different parts of the body. We suspect that there is a genetic basis to this, but the actual specific genetics is not clear. One thing, and I don't know if I've mentioned this previously or not, I think I have, is that what triggers or brings on the autoimmune attack on some part of the body is an infection. Because the person's immune system apparently cannot, quote, tell the difference between the bad guy, the virus or the bacteria, and part of their own body. So what triggers or brings on the rheumatic heart disease, an autoimmune disease, is strep throat. Now, for most of us, people get strep throat. It's pretty common. If you've had micro, it's Streptococcus pyogenes or Streptococcus viridans. Okay, there's lots of streptococci. And most of us, when we get strep throat, okay, our throat really hurts. We've got a fever. Our throat really hurts. And the doctor just prescribes amoxicillin, a type of penicillin. It kills the bacteria. We're fine. But for people who have a genetic predisposition to rheumatic heart disease, every time they get strep throat, and their immune system, their own immune system, starts to attack the bacterium, which is fine, it simultaneously attacks the endocardium and valves of their heart. So therefore, for these people, we've got to be very careful with them about them not getting strep throat infections. This becomes an issue in dentistry as well, because there are many streptococci bacteria endemic to the mouth. For the future dental hygienists, you will learn that the principal bacteria that creates plaque on teeth is Streptococcus mutans. So there's lots of streptococci in the mouth. And so, but people who have this, in fact, up until a few years ago, the American Heart Association, as well as by law in the state of California, anybody who indicated they had a history of rheumatic heart disease had to be pre-medicated with an antibiotic before any dental procedure, including cleaning their teeth, could be done. And most dentists still, to this day, if they're dealing with a patient with a history of rheumatic heart disease, pre-medicate them with an antibiotic before they do any treatment. Have you heard of that? Mm-hmm. Who's heard of that?
Yeah. Isn't when you have like a local
No, that's a different issue. Yeah, that's a problem with that would be another reason for possibly pre-medicating them, but that's a little bit different than this attack on the valves. Now, in fact, streptococci bacteria seem to be not only the trigger for rheumatic heart disease, but also rheumatoid arthritis, which is an autoimmune attack on the synovial joints, as well as lupus, or lupus erythematosus, which is an autoimmune attack on the skin, as well as another autoimmune disease of the brain that I'm not going to get into. So here, the way I wrote this as far as rheumatic heart disease, it's where there's a cross-reaction between the streptococcus infection and the valves of the heart. So this is one of the cases where they will prophylactically or preventatively give antibiotics. Now, there are two types of valve problems. Any of the four valves can have a problem. Could be one of the four, could be all four. The valve is described as either being stenotic or insufficient. And I think the best way that I can try to explain this is the following way. And it would be best, I've got a camera here, so I'm trying to stay in front of the camera. So my voice will go off into the distance. Here, you can make out a door over here. All right, here's a door. Now, the problem with the door could be that the door doesn't open all the way. Imagine the door shuts fine. It shuts fine, but it doesn't open all the way. When a valve will shut okay, but it doesn't open all the way, we say it's stenotic. There's stenosis. There is a narrowing of the opening. The opening is narrowed, constricted. It doesn't open all the way.
It's stingy.
It's stingy. It's stingy door. Stingy hinge. It's got a hinge too. So it's a stingy hinge. All right, now, it could be the opposite problem. It could be that the door opens fine, but it doesn't Shut. If the door or valve opens fine, but it doesn't shut, we say it's insufficient. Both problems are equally bad, and they both fundamentally result in a decreased blood flow and regurgitation. So that's what I wrote. The stenotic valve shuts, but it can't open all the way. Thus, there's reduced flow through the valve. And on the next page, 178, an insufficient valve is a valve that opens but doesn't shut completely, so it regurgitates backwards. Now, in both cases, in both stenosis and insufficiency, there's a reduced forward flow of blood from going from one chamber to the next. And again, you've got to know the order, just like this. Again, to repeat, we're talking about arguably the most important organ in your body. To not know how blood flows through the heart, you can't go to the health field without understanding that. Now, how do they know that somebody has a valve problem? It is diagnosed by auscultation. What does auscultate mean? To listen. So you have to listen for abnormal sounds. Because when the blood is either regurgitating or flowing backwards or not going forward, it creates a murmur or an abnormal sound when there shouldn't be one. What do they do if somebody does have a murmur indicating a defective valve, a valve that's not working right, either because it was congenital or a rheumatic heart disease? They replace that valve with a prosthetic, which means artificial valve. Prosthetic means an artificial valve. What do they look like? So on the next page on 179, on the bottom left is an actual photograph of a prosthetic or artificial valve. Kind of looks like a little marble surrounded by a cage. And they actually cut out the defective valve and they insert this little marble device. So that the blood literally, when it's being ejected or flowing, it causes the marble to move out of the way and the blood flows around it. And when it stops flowing, the marble drops back into place and stops the flow of blood. In the X-ray here on the lower, right, it shows a lateral view of somebody's chest from the side, revealing two prosthetic valves. If you read the legend here at the right, it describes them as having a prosthetic or an artificial aortic valve and mitral valve. Now, mitral valve is the term that most doctors use for which valve is the mitral? It's called the bicuspid or the left AV valve. So again, it's not so much that I'm testing you on anatomy, but you've got to know the anatomy of the heart because they're going to call it a mitral valve, and you have to know which valve that is. There's 4 of them. You got to know which one's which. Now, there are pictures at the top of the page. And I'm not going to take the time to go through each of these. This doesn't show every valve problem. It shows aortic stenosis and mitral stenosis, and it shows aortic insufficiency and mitral insufficiency. And it tries to convey that in this case, for example, on the top left on 178, because the aortic valve is stenotic, constricted, it doesn't open all the way, it's hard for the blood to go from the left ventricle into the aorta. So there's a reduced forward flow of blood from the left ventricle into the aorta. In this case here, it shows stenosis or narrowing of the left AV valve, also known as the bicuspid or mitral valve. So again, it's hard for the blood to flow, in this case, from the left atrium into the left ventricle, so it starts backing up. So just kind of walk your way through this. Again, I know you all had to learn the names of the valves when you took anatomy. Here we're just asking you to understand functionally what that results in. On the next page, it just shows pictures depicting insufficient valves. The way they've depicted insufficient valves is they show that in this case, here's an insufficient left AV valve or mitral valve. Notice it shows arrows going in both directions. Meaning the blood goes from the left atrium into the left ventricle and then it regurgitates backwards because the valve doesn't shut all the way. It doesn't close. So when it should be closed, it's not closed, so the blood regurgitates backwards. In this case, arrows going in both directions indicate that the blood, because of an insufficient aortic valve, the left ventricle ejects the blood out of the aorta and then it flows backwards right back into the left ventricle. Okay, on page 130, I'm sorry, 180, 180. Yep.
On page 179, with the big arrow, the left AV valve insufficiency, does that big arrow in the right ventricle, does that mean that it's blood's having a hard time going in?
It's trying to show that the blood's backing up. Okay, it's just when the blood's not going forward, it starts to back up. But anyhow, on page 180, let's review another subject that you all covered in anatomy, and that's the blood supply to the myocardium of the heart. Now, in this picture, this anterior or front view of the heart, it shows
The aorta.
and the oxygenated blood is being ejected out into the aorta and from the left ventricle. And there's really about 100 smaller arteries that branch off the aorta. I talked about all this last time, and it's on the video of my video review of anatomy. The very first little arteries to branch off the huge aorta are the right and left coronary arteries. They are the very first arteries to branch off the aorta. Their job is to supply oxygenated blood to the myocardium of the heart. And they form many anastomoses with each other. There's a lot of interconnections. The word anastomoses means interconnections.
You'd say, well, say that again, because you haven't explained that previously.
Yes, I did. It was already in your notes. We covered it last class meeting. The definition of a capillary bed is an anastomotic network of capillaries, an interconnecting network. So we covered that on page 179. Anyhow, this is also known as collateral circulation, and you should know that word. Now, it's generally believed that the more anastomoses you have, the better off you are. Because if there's a blockage or an obstruction of any of these little vessels, if they have lots of interconnections, the blood can still circumnavigate around and deliver oxygen and sugars to all the cells, even if there's a blockage in any one little branch, because they make lots of interconnections. Now you might say, well, that's wonderful. I'm glad that having a lot of anastomoses is considered healthy, but what am I going to do about it? How can I possibly increase the amount of anastomoses or interconnections to be in better shape in case there's a blockage? And the answer is cardio workouts, aerobic exercise. Aerobic exercise, we know, strengthens our heart. It makes our heart grow bigger and stronger. That's called hypertrophy of the heart. And it also increases vascularization. It increases anastomoses. It increases collateral circulation. So aerobic exercise has these major benefits on the heart. Really, all you have to do is talk to, not academics like me, talk to doctors. Doctors are really good overall in doing aerobic exercise. They know how important keeping the heart healthy is. So they're all fanatics in terms of doing that. Now, on the back side of the heart, there is a large vein called the coronary sinus. So here, this is a posterior view, of the heart from the back side. And here, there shows many small cardiac veins that flow, where the blood flows into this coronary sinus, and the blood flows from the coronary sinus into the right atrium, along with blood from the superior vena cava and inferior vena cava. I reviewed all of this last class meeting, and you can watch my video or any of the other videos. Make sure you understand the flow of blood through the heart. I can't emphasize that enough. That's a common place where students get confused, and that's a problem with anatomy. Okay, now, so we see in this picture on the top left, it just tries to convey to you that if we were looking at cardiac muscle tissue, we will see capillaries, branches off the coronary vessels that are running in between all the heart muscle cells to provide them with oxygen and sugar. on page 181. At the bottom of 181, we wrote on the bottom of 181 that the heart is the organ most prone to ischemia. Now, ischemia means lack of oxygen. In fact, we can use the word ischemia and apply that word to any tissue of the body. Renal ischemia, cerebral ischemia, hepatic ischemia, muscular ischemia. But the most familiar way of saying that word ischemia is myocardial ischemia. That is the heart muscle is the most common tissue that suffers from lack of oxygen. I indicated there are 3 reasons for this. I'm only going to explain 2 of the 3 reasons. One of the reasons why the heart, of all the tissues of the body, is most likely to suffer ischemia, not enough oxygen, is that it works really hard. It needs a lot of oxygen to produce lots of ATP. And incidentally, heart muscle really is limited. It really is designed to generate ATP principally only aerobically. So it has to carry on aerobic respiration to generate lots of ATP, and it needs lots of ATP because it works really hard. Here I just wrote, needs lots of oxygen for cellular respiration to make ATP. In contrast, do you think your skin needs as much sugars and oxygen to generate lots of ATP? No. And how about your pancreas? Even your kidneys, they don't need as much ATP generated by aerobic respiration as your heart muscle does. But there's another reason, and I'll skip letter B and go to letter C. There's another reason why your heart is most likely to suffer from ischemia. It is one of the few tissues or organs of the body that only receives blood intermittently, 24 hours a day. Most tissues and organs of the body have a continuous flow of blood. But in the case of the heart muscle, it only receives blood intermittently. Let me try to explain why that is. In this picture at the top left, it shows that the fact that this is heart muscle, and it shows capillaries, vessels running through it. When any muscle, skeletal muscle, visceral smooth muscle, when any muscle contracts, as it contracts, it gets smaller. That's what contraction means. And as the muscle contracts and gets smaller, the blood vessels within that muscle are compressed shut. So in other words, if you contract your biceps right now, go ahead, tighten them hard.
Oh, my blood.
Keep them tight. As long as you keep that biceps muscle contracted, the muscles surrounding the capillaries running within the muscle have been compressed shut, and it's not getting any oxygenated blood. That's why when you try to keep a muscle contracted for any length of time, the muscle isn't getting oxygen, so it's generating ATP anaerobically, forming lactic acid. And that lactic acid causes it to fatigue. And at a certain point, you have to say, I can't keep my muscles contracted any longer. So all muscles, when they contract, they stop getting blood flow. The moment you relax the muscle, now the blood starts to flow through the vessels, nourishing that muscle again. All right, everybody got that? This happens in all muscle. Contracting the muscle squeezes or compresses the vessel shut, so it's not getting oxygen at that time. But there's very few muscles in our body that we use 24 hours a day. We don't use our biceps brachii 24 hours a day. We don't use our quadriceps 24 hours a day. The heart muscle, 24 hours a day. Every time it contracts, it stops getting oxygenated blood. Obviously the diaphragm also works 24 hours a day, but it doesn't contract as frequently. When we're sleeping, we might be breathing at a rate of maybe 10 breaths per minute. But our heart, even when we're relaxed, is at least beating 60 or 65 beats a minute. And so every time it contracts, it stops getting oxygenated blood flow. This is called intermittent blood flow. It gets blood intermittently. Every time the heart muscle contracts, it stops getting oxygenated blood. When it relaxes, it starts getting oxygenated blood again. We can see this on a graph on the next page. And physiologists love graphs. Okay. Now, this graph is complex and showing a number of things. In fact, there's two graph lines here, and I'm really going to just focus on part of this. First off, what it's showing is on the x-axis. We always like to get our bearings. On the x-axis, it's showing time going by, and the units are seconds. It shows two graph lines, an upper one and a lower. The upper line is indicating blood pressure in the aorta. This is blood pressure in the aorta. Again, this is what we're going to be learning about, blood pressures and volumes, stuff like that. But if you don't know what the aorta is, you're not going to understand what I'm talking about. That's anatomy. The lower graph line is showing blood flow in milliliters per minute through the left coronary artery. That's what I want to focus on, the left coronary artery. Now, you'll notice that right here at the top, it's labeled at the top that this is systole. What is systole? Systole is the period when the ventricles contract. This is systole. Right up here, it says diastole. This is the period during diastole. What's diastole? When the ventricles relax. You'd say, okay, so what? What I'd like you to do here's blood flow through the left coronary artery. I want you to notice it's showing, it's a very complex pattern. I could explain all of it, but I'm not, because we don't have time. But I'd like you to notice that this is the amount of blood flowing through the left coronary artery, which is providing oxygenated blood to the left side of your heart. All right? Can you see how the blood flow decreases to 0? Does everybody see that? Blood flow drops to 0, and then it starts to go up again. What point in the cardiac cycle did blood stop flowing through the left coronary artery? Can everybody see that occurs during systole? So at some point during systole, when the ventricles contract, the muscle contracting squeezes shut the left coronary artery, so it's getting 0 blood flow through the left coronary artery, a major vessel supplying oxygenated blood to the heart muscle. Now, you can see that after that, blood flow increases. It goes up, it goes down a little bit, goes up. And at what point in the heart cycle was there a maximum amount of blood flowing through the left coronary artery? Right here. This is the point where it gets maximal blood flow. Can everybody see that occurs during diastole? So it is during diastole where the greatest amount of blood is flowing through the left coronary artery. When was there the least blood flowing? During systole, right here. For the reasons I've given, when the heart muscle contracts, it squeezes shut the left coronary artery, so the heart's getting no oxygen. During diastole, when the ventricle is relaxed, that's when you get maximal blood flow. Why it varies in between it has to do with variations in pressure in the aorta, which are superimposed upon this, but I'm not going to get into it. So in summarizing, the heart has two huge problems. The heart needs a lot of oxygen, more so than almost any other organ. It works hard all the time, 24 hours a day, 7 days a week. It never stops. And it's also one of the few tissues in the body that gets intermittent blood flow, 24 hours a day. It never gets a continuous flow of blood. Your kidney gets a continuous flow of blood. Your liver gets a continuous flow of blood. Now, we know that muscles, when they contract, they don't get the blood flow. So the heart is not the only muscle where it doesn't get blood flow when it contracts. It's just that it's almost one of the few muscles that works 24 hours a day. So it's got two huge problems that most other tissues in the body don't have. As a result, let's look in this bar graph on the lower right. This bar graph is indicating, and I wrote this at the top, the delta AVO2. So our first thought is, what the hell is the delta AVO2? That means the arteriovenous oxygen difference. The difference in oxygen between the artery and the vein. Arteriovenous. That's what it says here. Arteriovenous. Not atrioventricular in this case. Arteriovenous oxygen difference. All right, so let me explain this. Can everybody see here it says kidney? Right? It's got kidney. So here's a kidney. This is the renal artery that carries oxygenated blood into the kidney. This is the renal vein that carries blood out of the kidney. We can measure what the oxygen content in the renal artery is, and we can measure what the oxygen content in the renal vein is. That difference in oxygen between the renal artery and renal vein is called the arteriovenous oxygen difference. What's the difference in oxygen? Obviously, we would predict that there's less oxygen in the renal vein than in the renal artery. The renal artery is carrying the oxygenated blood in, and the renal vein carries the blood out. How much lower is the oxygen content in the renal vein? 10% lower. That's it. The kidney only removed and used, extracted 10% of the oxygen available to it. That means that the oxygen content in the renal vein coming out of the kidney has 90% of the oxygen still there. The kidneys only extracted 10% out of all the oxygen available. The kidneys don't work too hard, and they get a continuous flow of blood. Now, we can do the same thing for the liver. I don't have a model of a liver to show you, but we can compare the oxygen content in the hepatic artery and the hepatic vein. If we compare the difference, the oxygen content in the hepatic vein is 20% lower oxygen than in the artery. These are called arteriovenous oxygen differences. So the liver's taking a little bit more oxygen from the blood than the kidney. If we do this with the brain, all right, so if we compare the carotid artery, which carries oxygenated blood to your brain, with the jugular vein, which is bringing blood down from your brain, we would find that the jugular vein is 30% lower in oxygen than the carotid arteries. So that means that your brain is removing and using 30% of the oxygen of the blood going through the brain. Does everybody follow this? This is called the arteriovenous oxygen difference. Now let's do this for the heart. All right, we've got... put my heart back together again. All right, now we've got a coronary artery right here. And on the back side, we've got this huge coronary vein called the coronary sinus. So let's just compare the oxygen content in the coronary artery. Now I have a broken heart. All right, let's compare the oxygen content in the coronary artery with the coronary sinus. So what's the difference in oxygen? 70%. The heart is removing 70% of the oxygen. And this is at rest when you're sitting in a chair. There is no other organ even close to removing so much of the amount of oxygen as the blood flows through that tissue. As the blood flows through that tissue or organ. Why is it removing so much? For the reasons we've given you. It works really hard compared to other organs, and it only gets blood intermittently. Every time it contracts, the heart stops getting any blood flow. It only receives blood flowing through the coronary vessels when the heart muscle is relaxed. So it's intermittent delivery of oxygen. Now, in spite of this, obviously that's still fine. It's got a 30%, excess. But what do you think happens as you go from sitting to walking and running? How do you think that's going to affect the amount of oxygen your heart muscle starts extracting from the blood? It starts to increase. So as you make your heart, all right, it's going to be taking more and more and more, 75, 80, 85%. Now, as long as you've got good, wide open coronary arteries, you're still okay. But what if your coronary arteries are clogged up? Then this is going to be a problem, because as you start to speed up that heart rate, it's not going to be getting enough oxygen, the heart. And that's going to lead to myocardial ischemia as your heart rate speeds up. This problem is known on the next page, on 183, as coronary artery disease, or CAD. Now, coronary artery disease is the accumulation of crud, mostly cholesterol and fat and calcium, on the inner walls of the coronary arteries. Now, this problem doesn't just develop in the coronary arteries. As I pointed out previously, this buildup of fatty plaque on the inner walls of our arteries occurs on all arteries of the body. But the consequences are not as dire. They are not as critical when you get clogging up of the renal artery or clogging up of a pancreatic artery, because they've got plenty of excess blood flow. But the coronary arteries are working at a very narrow margin of safety. And when these coronary arteries get progressively occluded, and this is showing a series of cross-sectional views, drawings through the coronary artery, notice what's happening to the lumen, the opening through which blood flows through the vessel. It's getting narrowed, constricted, stenotic. And so this stenosis of the lumen, as I wrote right here, this stenosis or narrowing of the lumen due to the progressive occlusion due to the buildup of fatty plaque is reducing coronary blood flow. This is going to lead to myocardial ischemia. Now, this is going to be especially a problem whenever the heart rate speeds up. So even if you're getting enough blood flow through this occluded, clogged up coronary artery when you're sitting, anytime you're stressed, physically or emotionally, what does stress do to your heart rate? Speeds it up. That means it needs more oxygen because it's working harder. It's not getting the oxygen it needs. It starts to form lactic acid, and this creates a pain, a referred pain called angina pectoris. So angina pectoris is a referred pain to the left shoulder and left arm. In males, it is commonly perceived as felt as coming from the left side of the chest and left shoulder, radiating down the medial side of the left arm. In women, it may actually manifest itself or present itself in both arms, and also nausea. So that just as that we've mentioned that there are ethnic differences among people, which really reflect genetic differences. Last time we talked about how renal hypertension is more common in individuals of African ancestry and more rather than essential hypertension. There are gender differences. And so there are different, but again, we can't get too detailed in this course. That's what you'll learn more about when you go into more advanced courses, is differences among genders and differences among individuals of different genetic populations. Here it just tries to show how these coronary arteries are all clogged up. So even if there's sufficient oxygenated blood flowing when you're sitting, there is not sufficient oxygenated blood when your heart starts to speed up during stress and it needs more.
How can you unclog them?
We're going to get to that right now. So on page 184, yep.
On the same page, 183, what are the black dots that are...
What are the who?
The black like plaques or dots or...
That's calcium, calcification. Yeah, it says it in the legend. Okay, on page, went the wrong way here, on page 184, so we said that angina pectoris is caused by myocardial ischemia, but it's a referred pain. This especially occurs during states of stress, where the heart starts to work harder and needs more oxygen as it isn't getting it. Now, what do you do when you've got this, and how do you reduce the problem? All right, they commonly have people take what are known as coronary vasodilators. Now, the most common of the coronary vasodilators, drugs that dilate and open up the vessels to increase blood flow, is nitroglycerin. Nitroglycerin mimics the action of nitric oxide, the neurotransmitter. You might remember we also showed you that article about Viagra, which also has the effect of increasing nitric oxide. That's why there was the warning not to take a coronary vasodilator like nitroglycerin at the same time as Viagra. You get too much vasodilation. Now, nitroglycerin doesn't just dilate the coronary arteries, it dilates all vessels. So that's commonly what people take whenever they experience angina. And the most common way that they take it is they usually put it sublingually under their tongue. That's just a temporary relief of dilating the vessel and increasing oxygenated blood flow to the heart muscle to take away that pain that the person is feeling in their left shoulder. All right? That just means their heart isn't getting enough oxygen. We don't care that their shoulder feels like it hurts. We're worried that the heart isn't getting enough oxygen. But how do you provide better relief over a longer term? So another method that's commonly done is coronary angioplasty. Angioplasty is where they insert a catheter into the clogged up coronary artery and they inflate a balloon. That doesn't get rid of the fat. All it does is push the fat harder against the side walls to open up the lumen more. One of the newer methods is to, after they inflate the balloon, which is shown right here, they insert a stent. The word stent, and I wrote the word coronary stent, is like it's like a kind of Teflon covered cage. And it's like a cage. They actually insert it and expand it in the artery so that it kind of opens up that vessel wider. So that now there's kind of this device that's keeping the wall of the vessel expanded. But none of these are really permanent solutions. So when somebody, even after they've done the coronary angioplasty and even inserted a stent, it may be only a matter of time before they need something called a coronary bypass surgery. In coronary bypass surgery, they take arteries from somewhere else in your body where you don't need them so critically, and they bypass the most clogged up segments of the coronary artery. This particular picture shows what we would call a triple bypass. You can have a single bypass, a double bypass, a triple, a quadruple, however many it takes. And that whole idea is to improve blood flow to the heart. Now, I've been describing what happens when you've got clogging up of the coronary arteries with fatty plaque. And it leads to myocardial ischemia and creates this referred pain called angina pectoris. There's a much worse problem that can develop. And the worst problem is that this clogging up of the coronary arteries with fatty plaque increases the risk of a coronary thrombosis. To help explain that, let's look on the next page. I think you've got an extra page in there, 184A. Is that right?
Yes.
Does everybody have that? Yes. So on 184A, okay. And if you had me for anatomy, I actually covered this in anatomy. All right. Now, on 184A, let's first of all tell you a little bit about what happens when you cut a blood vessel. We cut blood vessels all the time. We've all had paper cuts and cut ourselves. So here it shows a vessel, and the wall of the vessel has been cut. Circulating in our bloodstream all the time are these little guys called blood platelets. Blood platelets are also known as thrombocytes. Where are they made? They are made in our bone marrow. They are made in the same place where our red blood cells and most white blood cells are made, in our bone marrow. These are called platelets, or thrombocytes. They're always circulating in our bloodstream. Now, platelets are designed to attach or aggregate to rough edges of a vessel. So when a wall of a vessel has been cut, that creates rough surface And these little platelets, which are little pieces of cells actually formed in the bone marrow, they attach or aggregate to the cut edges of the vessel. This forms what's called a platelet plug. That's what we call it, a platelet plug. It forms a platelet plug, P-L-U-G. It's a little bit hard to read what I wrote. A platelet plug, which we'll learn more about later. But more relevantly, these platelets not only plug up that cut wall of the vessel, they release a chemical called PF, which stands for platelet factor. And it's all written there. So the platelets release a chemical called platelet factor. Platelet factor initiates a complex series of biochemical reactions right here that culminates in the formation of a fibrin clot. So what's formed here is a fibrin clot. Now the fibrin clot looks a lot like a spider web. It looks like a spider web. And the whole purpose of this fibrin clot, made up of a protein called fibrin, is to stop the blood from flowing through this vessel so that it doesn't go out through the cut in the wall of the vessel so you don't bleed to death. So that's the purpose of a fibrin clot, is to stop yourself from bleeding to death, which is a nice thing to do. Now, then what happens, and here's something I didn't cover in anatomy, but we are going to cover in more detail in this class, is that when the wall of the vessel is repaired, meaning it heals, meaning cell division occurs, and we make new simple squamous epithelial cells or new cells that form the wall of the vessel, whatever kind of vessel it is. All right, so now the wall has been repaired, and the healing cells, as they heal, release another chemical called TPA, tissue plasminogen activator. What TPA does is it triggers a protein circulating in our bloodstream. It activates this protein called plasminogen, causes it to turn into plasmin, and plasmin dissolves this fibrin clot. So tissue plasminogen activator, released by the healing cells, activates a chemical called plasminogen into plasmin.
You'd say, well, wait a second, say that again, I didn't follow it.
Does anybody remember when we talked about the renin-angiotensin-aldosterone reflex? Renin converted angiotensinogen into angiotensin. And I mentioned that commonly chemicals that have to be activated have the ending GEN, and when they go into the activated form, we drop that GEN ending. So it went from angiotensinogen to angiotensin. Similarly, plasminogen is turned into plasmin by TPA. What does plasmin do? It dissolves this fibrin clot. This is known as fibrinolysis. What does fibrinolysis mean? To break apart fibrin. So the fibrin clot is dissolved, and when the fibrin clot dissolves, now blood can flow through this repaired vessel. All right, so we have reviewed very briefly what blood platelets are, how blood platelets release a chemical that leads to the formation of a fibrin clot, how when the wall of the vessel is repaired or heals, it releases a chemical called tissue plasminogen activator that culminates in the dissolving of that fibrin clot and allows blood to flow through that repaired vessel. Everybody okay on that? On the next page, so let's see what happens when you've got atherosclerotic arteries. So in this picture, here's a vessel. It's not cut. I don't show any cut in the wall of the vessel. What I do show is it's got crud. It's got fatty plaque clogging up the inner wall. So this is the atherosclerotic plaque. it has not only reduced the lumen, we have an occluded lumen. So the lumen, the passageway, is occluded, narrowed, stenotic. But more importantly, even more importantly than that, this has created a rough surface. And the blood platelets, we said, are designed to attach and aggregate along rough edges, rough surfaces. Normally, what would have created the rough surface is a cut in the wall of the vessel. In this case, the vessel wall isn't cut, but there's this crud, this atherosclerotic plaque. The platelets aggregate, they release PF, platelet factor, and platelet factor causes a fibrin clot to form. So a fibrin clot is forming in this vessel. Maybe it's a coronary artery, and it's not because the vessel was cut. So, CAD, what is that? Coronary artery disease. What is that? That means atherosclerosis in the coronary artery increases the risk of a coronary thrombosis, a blood clot forming in the coronary artery. When that blood clot forms, now we've got zero blood flow through the vessel. Not reduced blood flow, zero blood flow. So now no oxygenated blood is flowing through this vessel. As a result, it is likely that part of the heart muscle will die because you've blocked blood flow completely through this vessel. When a tissue dies, the term we use is infarction. Infarct means dead. So where's the infarction or death? Myocardium. A myocardial infarction, abbreviated in MI. Or what lay people call a heart attack. A heart attack is when the heart muscle dies. Now, what they can do is if this clot, this is called a coronary thrombosis, it was really due to a blood clot being initiated because of all that clogged up fat on the inner wall of the coronary artery. We had said on the previous page that there is this chemical called tissue plasminogen activator, or TPA, that can activate this protein circulating in our bloodstream called plasminogen, turn it into an active form called plasmin that dissolves the blood clot. So in fact, what they give to people now when they have a heart attack, a myocardial infarction, a coronary thrombosis, is they give them synthetic, genetically engineered synthetic TPA. The TPA is then given, which activates the plasminogen into plasmin, which will dissolve that clot. If they can do that within about 15 or so minutes after the formation of that clot, the blood will flow through that vessel again, and the heart muscle will recover. Because brain cells can live 4 minutes, heart muscle cells can live 15 or more minutes, maybe 20 minutes. Okay? So they can go a little bit longer than brain cells without the oxygenated blood. So that's what they give is TPA, tissue plasminogen activator, to dissolve that clot.